Hi everyone, welcome to RCM Mastery. Today we are going to completely demystify one of the biggest headaches in medical billing, the dreaded global to surgery denials. If you are sitting there staring at unpaid claims, trapped in postoperative limbo, you are exactly in the right place. We're going to take this nice and slow, making sure every concept is crystal clear so you can take these strategies straight back to your accounts receivable queues and start getting those claims paid. So, here is our game plan for this explainer. First, we will define the core issue, which is the global period itself. Then, we're going to equip you with 4 very specific tools to fix these denials, modifiers 24, 58, 78, and 79. Let's get right into it. Section 1, the global period. This is the root of the denial, because to fix the problem, we really need to understand the strict rules around the post-operative timeline. Okay, so what exactly is the global post-operative period? Well, when a patient has a major surgery, the insurance payer basically sets a 90-day global window. Think of it like an all-inclusive package. All the routine, expected follow-up care provided by the surgeon during those 90 days, it's already bundled right into that original surgical payment. So if you just bill a routine visit during this window, bam, automatic denial. To actually get paid for separate services, we have to prove to the payer that this new service is totally outside of that bundled care. Moving to Section 2, Modifier 24 for Unrelated EM, which stands for Evaluation and Management. This is our very first tool for breaking outside of that bundle. Let's look at the exact definition. Modifier 24 is an unrelated evaluation and management service by the same physician during a postoperative period. Basically, appending this modifier is your way of telling the insurance company, hey, look, I know we're inside that 90-day global window, but the provider is evaluating this patient for a completely unrelated issue. Now, you have to be super precise here. Rule number 1, never, ever use modifier 24 with surgical codes. It is strictly for EM codes. Also, getting separate payment for an EM visit while the patient is still in the hospital for the original surgery, not usually allowed. But there are a few critical exceptions. You can use it if a transplant surgeon is doing immunotherapy management or if the provider is giving critical care for severe injuries or burns. You can also use it if you have rock-solid documentation proving the care during that hospital stay is 100% unrelated to the surgery. And you can see this laid out in the official policy guidelines. When you successfully use modifier 24 in the right situation, your reimbursement is 100% of the allowable amount. That's huge. But look closely at the emphasis on documentation. To actually secure that full payout, you've got to attach documentation to the claim, proving without a shadow of a doubt that the care was truly unrelated. Section 3, Modifier 58. This one covers staged procedures, which means planned or more extensive care. So, Modifier 58 is officially defined as a staged or related procedure or service by the same physician during the post-operative period. Basically, using this modifier says, we expected to do this subsequent procedure. It was part of the plan. And just like with modifier 24, if you apply 58 correctly, you are looking at 100% of the allowable reimbursement. You're going to use this modifier in 3 very specific situations. Number 1, it was planned prospectively when the first surgery happened, meaning the doctor already knew a second step was needed. Number 2, the second procedure is much more extensive than the first one. Or number 3, it's a therapeutic follow-up to a diagnostic surgery. But please, pay close attention to this last point. You absolutely cannot use modifier 58 if the patient has to go back to the operating room because of a complication. Just don't do it. You can actually see the official warning right here in the coding manual. It explicitly says, modifier 58 is not for reporting the treatment of a problem that requires a return to the operating room. If you try to use it for a complication, it's going to trigger an immediate and frankly justified denial. Which brings us to Section 4, Modifier 78. This is all about related returns and how we actually handle those complications. So, if 58 is out for complications, what's our tool? It's Modifier 78. Defined as a return to the operating room for a related procedure during the postoperative period. If your patient has a complication directly from the first surgery, like an infection or maybe internal bleeding, and the surgeon has to rush them back to the OR to fix it, modifier 78 is exactly the code you need on that claim. Let's break down the golden rules for 78. The procedure must be related to the first surgery, and it absolutely must require the use of an operating room. Oh, and it's totally fine to use for same-day complications too. But here is the single most important thing to remember about modifier 78. It does not reset the clock. A brand new 90-day global period does not start. You are still working within the original 90-day window from that very first surgery. Finally, we have Section 5, Modifier 79. This is for unrelated procedures, meaning completely new issues. Modifier 79 is defined as an unrelated procedure or service by the same physician during the post-operative period. Imagine a patient has major abdominal surgery, but then 3 weeks later, they trip, fall, and severely break their arm, and the same doctor has to surgically repair it. That arm surgery has literally zero relation to the abdominal surgery, right? That is the perfect time to use Modifier 79. Now, the burden of proof here is entirely on you and your coding team. To successfully overturn a denial with Modifier 79, you have to clearly prove medical necessity. The absolute golden rule here is that your diagnosis codes for this new service must be completely different from the diagnosis codes used for the initial procedure. If those diagnosis codes match, the payer is going to assume the procedures are related and they're going to deny your claim. As you can see, verified here in the coding manual, correctly applying either Modifier 78 or Modifier 79 ensures the provider gets 100% of the allowable reimbursement. It's just a great reminder that picking the right modifier doesn't just clear up a denial in your system, it actually secures the full, correct revenue that your practice deserves. Okay, let's look at these two side by side because mixing them up is a really common mistake. Remember, use Modifier 78 for related complications that force a return to the OR, and keep in mind it does not reset the global clock. On the flip side, use Modifier 79 for entirely unrelated procedures, and make absolutely sure you use different diagnosis codes to prove it's a completely separate issue. We've covered a lot of really crucial ground in this explainer today, but the real test is how you apply it. Take a good, hard look at your current accounts receivable queues. How are you going to methodically use modifiers 24, 58, 79, and 79 to clear out those specific global-to-surgery denials today? Review your documentation, double-check those diagnosis codes, and append your modifiers with absolute confidence. If you found this video helpful, please hit like and subscribe for upcoming videos.